Our next esteemed speaker is Dr. Saumitra Ray from Kolkata. Dr. Saumitra Ray is a Director, Invasive Cardiology, Emory Hospital, Kolkata, Professor, Vivekananda Institute of Medical Sciences, Kolkata, Executive Committee member and ex-Vice President CSI, and pursued MRCP in UK after completing MD from Calcutta Medical College and got FRCP, trained in cardiology at the Royal London Hospital, London, published many papers and research articles. He's on editorial board of several journals and has represented CSI International Meeting and the founder president in cardiology, Calcutta Cardiology Foundation. I'll request the chairpersons, Dr. George Koshi, Dr. Balveer Kalra, Dr. Prabhat Pandey. Dr. George Koshi, please start the session.
Thank you, Dr. Manoria. I think the most important aspect of the long-term management of atrial fibrillation is really stroke prevention. Prevention of thromboembolic episodes by appropriate anticoagulation. All other things are secondary, like rate control versus rhythm control and things like that. And to speak on this, we have Dr. Saumitra Ray. Listening to him is always a pleasure because of the clarity of his expression. Please go ahead, Dr. Saumitra Ray.
Thank you, Dr. Koshi. Thank you, Dr. Manoria, and thank you, Team Global Cardiometabolic Update. As Dr. Koshi has rightly said, I don't know how I got that message from him before, because you see that my next slide is from basics. The worst thing about AF is not AF, but ischemic stroke. That's exactly what Dr. Koshi just said. And why is it the ischemic stroke is so bad in AF? Not just because there is 5 times more risk of ischemic stroke in AF, but the severity after a stroke in AF is twice as much as an ischemic stroke in sinus rhythm, say due to hypertension. The severity is twice as more. 30-day mortality is twice if the stroke is related to atrial fibrillation. 6 months mortality is twice because of an AF-related stroke. Longer hospital stay, and 1 year stroke mortality, if it is AF related, is 3 times more than if it is not AF related. So AF not only increases the rate of stroke, but it increases all the associated morbidity and mortality which comes as a baggage with a stroke. Now, if you see again, of the all ischemic strokes, around 20% are purely cardiometabolic and 25% are cryptogenic. And of this cryptogenic, most of them are aortic atrial fibrillation. So you can say roughly 40% of ischemic strokes are directly or indirectly related to atrial fibrillation. How to detect when the person is a sinus rhythm that he is having paroxysmal AF? Because that is very important. You have to make your strategy of stroke prevention if you detect paroxysmal AF. One 24-hour halter can give only 0.2% success rate. If you make it 6 24-hour halter, it becomes 10 times more. If you make it 2 7-day halter, the 4% of patients you can detect. But if you put an implanted device, then today or tomorrow, you will detect that hidden paroxysmal stroke. Now, what are the standard recommendations once you get this paroxysmal or permanent stroke? I will base my presentation on 2020 ESC guideline and 2021 EHRA guideline. This is a busy slide, but it's worth reading. I'll spend a minute on it. Patient with AF who is eligible for OAC, and who are eligible, I'll come to that later on. First, see whether he is having a mechanical prosthetic valve or a moderate to severe mitral stenosis. If yes, then we have to resort to warfarin even in today's world. But if it is not, then we have to find out the CHADVA score, 0 in male and 1 in female, because this one comes from the female gender herself. Then no antithrombotic treatment. If the 1 in male and 2 in female, then address the modifiable bleeding risk factor in all AF patients. I'll clarify that. Calculate the Hasbled score. If the Hasbled score is 3 or more, address the modifiable bleeding risk factor and flag up the patient, warn the patient for regular review, and a closer follow-up is indicated. High bleeding risk, this is very important, mind it. High bleeding risk score should not be used as a reason to withhold OAC. So Hasbled score never interferes with your decision of starting OSC, but it tells you follow up the patient closely and you counsel the patient closely. Now, CHA2DS2-VASc score, if 1 in male and 2 in female, then this is a class 2A indication for OSC. Some people advocate aspirin, but again, it is controversial. But if it is 2 or 3 in female, then it is class 1 indication for OSC. And now, if it is OSC, NOACs are generally recommended as first-line therapy over warfarin. Now, I just clarify, if it is male and 1, and if that 1 score comes from hypertension, then it becomes class 1A recommendation for oral anticoagulation. Now, the ACC just passed ACC 2019. They said NOACs are recommended over warfarin in NOAC eligible patient, as I already mentioned. So transatlantic, they agree on that. Now, we all know CHA2DS2-VASc score, don't we? But I think personally that I need some clarification myself. What is the C? C is just not congestive cardiac failure. It is, if you see the right side, recent decompensated heart failure irrespective of ejection fraction. That means heart failure with preserved ejection fraction as well, or an asymptomatic patient with low ejection fraction. So both extreme, as well as hypertrophic cardiomyopathy, which comes into this congestive cardiac failure. So C is important. Hypertension, as I said, but more important, history of hypertension or patient on antihypertensive therapy. Maybe when you are assessing, his blood pressure is 120/80, but you give 1 point if there is history of hypertension or if the patient is taking medicine, because history may result in vascular damage that predispose to stroke. And a well-controlled blood pressure today may not be well-controlled tomorrow. But if the pressure is uncontrolled, you must control it before starting the OSC unless there is an emergency. Age, always, the more the age, the worse the outcome. And of course, 75 years or above is 2, 65 years or above is 1. Diabetes. Now, diabetes is an well-established risk factor, particularly in Indian setup, both type 1 and type 2 diabetic. But funnily, a younger patient with diabetes has got more risk of a stroke with atrial fibrillation when they are below the age of 65. Now, stroke or previous history of stroke or TIA, or you see thromboembolism, peripheral embolism is included into the stroke, and you give a strong point of 2 here. Vascular disease is very much included nowadays, and angiographically significant CAD, previous heart attack, peripheral disease, or even aortic plaque, abdominal aorta plaque, thoracic aorta plaque. This is included into the vascular disease because they variably increase the risk of stroke by around 30%. And age, as I mentioned, sex is merely a risk qualifier. So maximum score is 9. And if you see, as the CHA2DS2-VASc score, the event increases exponentially once the score is beyond 2. Now, what is Hasbled score? Here, the H is hypertension, but it is an uncontrolled hypertension on the day you are looking into the patient. And that is the systolic 160. Diastolic is not mentioned. If you get, there is history of hypertension and your hypertension pressure today is 130, your H is 0, not 1, as opposed to CHA2DS2-VASc score. Abnormal renal and hepatic function very clearly defined. Stroke, you see stroke is on both sides, and hemorrhagic stroke is of course here. Bleeding history or predisposition. Labile INR, which is only applicable if the patient, you are thinking of warfarin. And labile INR means when the time in therapeutic range is below 60%. Elderly or frail patient, they are more prone to bleed. And drugs or excessive alcohol means more than 1.4 unit per week, or concomitant antiplatelet or non-steroidal anti-inflammatory for rheumatoid or so on. So again, the maximum score is same as CHA2DS2-VASc, that is 9. Now there is a gray area. When the patient is put on a device, ICD or pacemaker, patient is pacemaker dependent. How do you know there is atrial fibrillation going on underlying? How do you know? You are getting, you can't see the P wave and there is just the pacing waves going on maybe. If it is a single chamber, there are many patients on single chamber today. Now there is an AHRE guideline it is a gray area. You have to one side see the CHA2DS2-VASc score. On the other side, you have to see the atrial high rate episodes as detected by Holter monitoring. So you do Holter monitoring even after putting pacemaker. That is very important. That Holter role is over when the pacemaker is put. That is not the issue. You have to do Holter from time to time to detect those paroxysmal AF. And the longer the duration of AF and higher the CHA2DS2-VASc score, you are more obliged to give the oral anticoagulation for the rest of the patient's life. And evolution of NOAC, as you know, there are plenty of big studies. What is the gist of those studies? Dabigatran 150 and apixaban have got superiority over warfarin as far as reduction of stroke and systemic embolism. Dabigatran 110 and rivaroxaban are as good as warfarin. When we come to only the ischemic stroke, not systemic embolism, only dabigatran 150 is superior, others are as good as warfarin. If we talk about major bleeding, here scores only dabigatran 110 this time and apixaban. Dabigatran 150 and rivaroxaban is as good as warfarin. And if we talk about intracranial bleeding, all NOAC at all doses are superior to warfarin. So that is the gist. Now there is a under usage of therapeutic anticoagulation. In the dabigatran RELY trial, 50% patients were eligible for lower dose. In real world, it's almost same. That is very encouraging. See, rivaroxaban, around 20% was eligible for lower dose, 15 milligram. But in real life, we are seeing 40% of patients are getting 15 milligram. So clearly, 20% are getting inappropriately low dose, which is magnificently amplified in apixaban. Only 5% are eligible for lower dose. And in real life, almost 35% are getting the lower dose. So 30% of patients are clearly getting inappropriately low dose of apixaban. And if you get that, what will happen? You will have more stroke and more death if you get inappropriately low dose. So what is the appropriateness of lower dose? Dabigatran, you get 110 if the patient is above 80, or the patient is taking verapamil, very interesting, or there is Hasbled score is 3 or more. Rivaroxaban 15 milligram you give only when creatinine clearance is 15 to 50. Apixaban you give the lower dose only if there are 2 criteria out of 3, age above 80, weight below 60, or creatinine above 1.5. Now we have got so many associated conditions with AF like CKD, and as you know, CKD is a contraindication relative, particularly dabigatran, and you have to give lower dose, as I said. But what about dialyzed patient? We still think warfarin is good for dialysis, but see this 2021 publication. Warfarin may be especially harmful in dialysis patient and should therefore be avoided, in particular with high bleeding risk and labile INR. Those finding studies of DOAC suggest rivaroxaban 10 milligram and apixaban 2.5 BD are the appropriate choice in dialysis patient. And left atrial appendage closure is an attractive alternative if the patient cannot tolerate this. In liver disease, you know, all are contraindicated up to Chuck-Puke score of 7 if there is normal dosing. When it is 7 to 9, you cannot use rivaroxaban, and others you use with caution. If it crosses 9, you cannot give any oral anticoagulation. That is a very unfortunate situation. What about stroke? If the patient is on NOAC and come with a stroke, you have to see whether the blood level is low, if possible, or if he has taken it more than 48 hours, then you can do the thrombolysis followed by clot extraction. And if it is dabigatran, and if you can reverse it with idarucizumab, you again consider thrombolysis. Otherwise, you have to go straight for thrombectomy. You cannot give thrombolysis. Now, you know that with acute ischemic stroke, how to manage. If it is a TIA, you might start the NOAC after 1 day. If there is some disability, you stop for 3 days. If it is a mild stroke, a lacuna stroke, about 3 to 6 days. If it is a more severe stroke, about 12 days. But you always have a second CT scan done before starting the NOAC to exclude a secondary hemorrhagic conversion. Now, what is CI? And we know there is a lot of controversy, lot of papers going on. make the thing simple. If it is an ACS patient, you give NOAC with aspirin clopidogrel for 7 days to 1 month, then continue with NOAC and clopidogrel for about 6 months to 1 year, and then give only the NOAC. If it is an elective PCI, everything comes a bit shorter. 7 days of triple therapy, 6 months of dual therapy, then after 6 months, monotherapy. So, but again, it depends on how prone the patient is for thrombosis and how prone the patient is for bleeding, and you have to make your own judgment individual patient. What about if the patient bleeds? If it is a minor bleed, don't bother, press the bleeding site if it is possible, and so on. If it is a moderate bleed, you give the supportive measure, you hold the NOAC for the time being. For dabigatran, you can consider itarucizumab or even hemodialysis. If it is life-threatening bleed, then of course you have to stop it, you try to reverse it, you try to give fresh frozen plasma or factor FXA inhibitor. And when to restart, reinitiate anticoagulation in the absence of absolute contraindication, and it has to be a very judicious shared decision making. Now we know that itarucizumab is available in India and Dexanet alpha is not yet. Itarucizumab is convenient because it is a 2 shots, and Dexanet is a continuous infusion, and there is some rebound phenomenon after reversal which is not seen with itarucizumab. Now my last 2 minutes, as Dr. Manoria said, on emerging concept. So what are the emerging concept? First emerging concept is on rescoring. AF type should be included in the rescoring because persistent or permanent AF has got more propensity for stroke than a paroxysmal AF. And even in paroxysmal AF, the duration of that paroxysm defines how prone the patient is for a stroke. BMI, this is very interesting. It is coming up, different guidelines. A low BMI causes stroke. Renal dysfunction, it is not included in CHA2DS2-VASc score so nicely, but it is threshold is not defined. Echocardiographic finding, we have totally ignored it so far. Fractional shortening, left atrial diameter, the smoke shadow or LA thrombus, why they are ignored? The biomarkers, HS troponin, NT-proBNP, they may be incorporated into the stroke assessment. Issues to remember, multiple risk scores are existing. CHA2DS2-VASc score is not universal. There is ART2-CHAD score, which includes renal, ABC score, age, biomarker, clinical history. Japanese are always different. They have their own JRE score, which is totally different. All parameters are dynamic. So there is a concept coming from Taiwan, delta CHA2DS2-VASc score. What is the difference from the last score I calculated and the score I am calculating today? If the change is more from 7 to 5 or from 3 to 6, the patient is more prone. There's a dynamic change is very important. Emerging concept on valvular heart disease. We know that that bioprosthetic valves, NOACs, can be given, proved by the RIVER trial with rivaroxaban. What about the mechanical valve? Absolute contraindication. But you see that 2020 pilot study, rivaroxaban 20 milligram was safe and effective in a pilot study of 10 low-risk patients with mechanical aortic valve, not mitral valve. The results justify a larger study. 21 came another study called RIWA study, again with rivaroxaban, but this time 15 milligram twice daily, and which showed similar thromboembolic and bleeding event with warfarin. They also say a longer study is required, which is now underway. But RMB study, rivaroxaban and mechanical valve, we have to wait with open arm. And the last emerging concept is prognostication, a new look. Non-cardiovascular death in AF is more common in real world data. So all AF patients don't die of stroke. 35% die of infection or malignancy in international Garfield registry, 40% in French registry, 66% in French nationwide database. So you see, AF does not only mean stroke prevention. You have to look into this as well. Net clinical benefit has been assessed on systemic thromboembolism and bleeding risk, but we should include the all-cause death for net clinical benefit. Otherwise, we will be myopic. We won't justify ourselves. And newer risk factors like BMI, low GFR, anemia, digitalis level, frailty predict more all-cause death than thromboembolic event because of an emerging concept OAC only came yesterday. Pacific AF phase 2 trial presented, which asundexian, which is a small molecule oral inhibitor of activated factor 11, which was well tolerated and significantly lower bleeding rate than apixaban. So here I stop and I say thank you to all of you.
Thank you very much, Dr. Saumitra Ray. So I think in 2022, there are very, very few indications for vitamin K antagonists because the NOACs are preferred. And regarding the reversal agents, most of the time the reversal agents are not required because these NOACs are all short-acting, so that if you stop the drug, the effect disappears.
I'll just come in, Saumitra, for a minute. It was very enlightening. And let me say, there is a recent new score which has come up called CHEST Spark score, which is in relation to risk prediction in past-like patient, as you know, coronary artery disease patients. So there is a new score which is just published last week that is called CHEST Spark score, where age is there. The another couple of things which you have added are there, like cigarette smoking is there, renal dysfunction is there, and severity of coronary artery disease is there, whether you have single vessel disease and the multivessel disease. So right now, I think it is CHEST-2 VASC score has lived its time. It needs to be more broadened with the current understanding, as you have suggested. I think we need to create a new score, a consensus kind of a score. We have enormous data. Now, academicians have to create a new score which is more adaptable to prediction, not only of AF, but other comorbidities. It was very enlightening, Dr. Saumitra, as always.
Dr. Saumitra, all guidelines recommend that patients of atrial fibrillation undergoing a PCI after 1 year, only oral anticoagulants are recommended. But suppose you have a patient who has left main stenting or multiple stenting, do you think OAC alone is sufficient, or these patients should also be put on a single antiplatelet agents? And there's no guide. What is the basis of this oral recommendation for the anticoagulants only post PCI after 1 year?
Sir, the people think that everything is endothelized, there is no platelet activation, and you are just treating the atrial fibrillation. So I absolutely agree with you. If there is any hint, then the patient may have a rough endothelium, there may be plaque fissuring going on an everyday basis, which happens every day in a plaque burdened artery, particularly in the left vein and other one. Then how come your oral anticoagulant just cover that? It is not possible. I think always there is benefit if you add a low intensity antiplatelet, but we have to assess the bleeding risk versus the benefit. I think everybody will agree that there is no argument about the benefit you get. Only argument is that whether the benefit justifies the added bleeding risk. I think the problem comes over there. It is a net clinical benefit which stops us.
And the single antiplatelet should be copied.
Saumitra, I have to come in because we don't have any kind of data or pilot studies on long term.
Yes. That's what Dr. Manoria said. We don't have evidence. It's a hunch-based treatment.
Full dose anticoagulation, which is with antiplatelet and maybe with something like Prax and Brillianta, it may be very messy situation. So I'll say it is a good concept, but not a reality.
Absolutely, sir. We can't endorse it.
Insights from the world's best medical minds. You are watching TheRightDoctors.com.